नमस्कार दोस्तों, वेलकम टू माय चैनल सिंप्लीफाइड न्यूरोलॉजी बाय डॉक्टर सौरभ गुप्ता। तो आज हम अपना स्टार्ट करने जा रहे हैं लॉन्ग क्लिनिक 4 अप्रोच टू क्वाड्रिपैरेसिस या क्वाड्रिप्लेजिया। इससे पहले हमने डिस्कस किया हाउ टू अप्रोच ए न्यूरोलॉजी केस, इसके बाद हमने डिस्कस किया हाउ टू अप्रोच ए स्ट्रोक केस और हेमीप्लेजिया हेमीपैरेसिस केस। देन लॉन्ग क्लिनिक 3 में हमने डिस्कस किया हाउ टू अप्रोच पैरापैरेसिस। तो आज हम स्टार्ट करते हैं हाउ टू अप्रोच क्वाड्रिपैरेसिस। क्वाड्रिपैरेसिस का जो केस है वो लॉन्ग केस की तरह मिलता है MBBS एग्जाम में, PG एग्जाम में, DMA एग्जाम में एज ए शॉर्ट केस वो आपको मिल सकता है। तो स्टार्ट करते हैं विदाउट डिले हाउ टू अप्रोच ए केस ऑफ क्वाड्रिपैरेसिस। So quadriparesis definition as quadriplegia is the complete weakness of all four limbs. So if there is a weakness of all four limbs, this is called as quadriplegia. If weakness is partial or incomplete, then it is called as quadriparesis. So this is the quadriplegia and the quadriparesis. So basically quadriparesis or quadriplegia, present with a varieties of presentation. So quadriplegia और quadriparesis के various variety of presentations हो सकते हैं, like only distal weakness, यानी कि all four limbs में distal weakness हो, उसमें भी quadriparesis हो सकता है। only या predominant proximal weakness of all four limbs, that is also a variety of presentation of quadriparesis. Symmetric या acute weakness of all four limbs, so only distal weakness of all four limbs, only proximal weakness of all limbs like in myopathy, distal weakness in neuropathy, symmetric onset weakness in all four limbs like in myelitis, acute myelitis, या फिर one limb then other limb of same side then opposite side involvement, like U-shaped type of involvement कि first affect the one limb then second limb then opposite side limbs. So this type of weakness may be seen in the compressive type of myelopathy, cervical myelopathy. So there are variety of presentation, only one side, only distal weakness, only proximal weakness, symmetric weakness in all four limbs, one limb involvement, then other limb involvement, then opposite side limbs involvement, or sometimes weakness of one side and then progress to the opposite side. So quadriparesis have various type of presentation, only distal weakness, only proximal weakness, all four limb symmetric weakness like in myelitis, involvement of the differential like first affecting one side of the body, then other side of the body, in one limb, then second limb, then third limb, then fourth limb. So there are various type of presentation seen in the quadriparesis or quadriplegia. Then as we all discuss in all cases in neurology, localization is always important, anatomy is always important. So all three questions should be in our mind: where is the lesion, what is the lesion, and why this lesion occurs. So start with the where is the lesion. So for quadriparesis, from brain to muscle, any lesion can cause the quadriparesis. So if this is our brain stem, this is the spinal cord. So in brain lesion usually does not classically cause quadriparesis. In case like very large space occupying lesion या very large infarct which involve the both hemispheres simultaneously, or patient having one side of weakness with left sided infarct, then within few days patient also develop other side weakness with infarct on the other territory. So a large lesion or simultaneously or recurrent infarcts in both hemisphere may causes quadriparesis like presentation. That is a very rare or very uncommon type of presentation. Then brainstem Brainstem may causes quadriparesis like presentation, but involvement of face and bulbar involvement usually seen. यानी कि with quadriparesis there is a involvement of cranial nerves. If there is a lesion in the brainstem, it usually causes involvement of the cranial nerve with quadriparesis. Isolated quadriparesis usually not seen in the lesion in the brain stem. So brain and the brainstem usually commonly not causes quadriparesis. It causes quadriparesis with associated symptom. In brainstem it associated with the cranial involvement. In brain it is associated with the headache, vomiting, seizure, loss of consciousness, altered behavior, loss of memory. Other cranial features should be present with quadriparesis. Then this is the cervical cord, this is the cervical cord, this is the thoracic cord, this is the lumbar, and this is the spinal cord. So lesion in the cervical cord can causes the quadriparesis. Commonly this is the common site of quadriparesis or quadriplegia. Thoracic cord, lumbar cord, and sacral areas, these areas does not causes quadriparesis. Lesion in the thoracic, lumbar or sacral lesion causes only paraparesis. So below cervical lesion, any lesion does not causes quadriparesis, it causes only paraparesis like presentation. So lesion in the cervical cord, it is a classical area for the UMN type of quadriparesis. So UMN type of quadriparesis lesion may be in the brain, brainstem, and maybe in the cervical spinal cord. Brain and brainstem, as I already discussed, usually does not cause classical quadriparesis. Classical cases of quadriparesis which is present in exam or in clinical practice, usually localization is mainly the either cervical lesion for the UMN type of lesion. After cervical, there is an anterior horn cell which is a part of element. Then roots forms the nerves, plexus. This is the plexus, nerves, then neuromuscular junction and muscle. So for element type of quadriparesis, lesion may be in the anterior horn cell, which mixed lesion, UMN plus element. Then roots, plexus, nerves, neuromuscular junction and the muscle. So all these area causes element type of quadriparesis. So for quadriparesis, lesion may be in the UMN type and the element type. UMN mainly lesion in the spinal cord, cervical cord यानी कि, rarely in the brain and brainstem. In brainstem, lesion is associated with the cranial involvement. In brain, lesion is associated with the seizure, loss of consciousness, severe headache, vomiting. Maybe large lesion can causes in rare cases. For element type of lesions, lesion may be in the anterior horn cell like motor neuron disease (MND). Lesion in the root, usually isolated lesion in the root does not causes quadriparesis because it causes the radicular pain. So roots involvement, isolate involvement of root is does not causes any quadriparesis type presentation. If root involvement associated with the neuropathy, nerve involvement like polyradiculopathy. Polyradiculopathy मतलब involvement of the multiple roots with multiple nerves can causes quadriparesis like presentation like in Guillain-Barré syndrome or CIDP, where root involvement with nerves involvement can causes the quadriparesis like presentation. After root, there is a plexus. There are two plexus, brachial plexus and the lumbosacral plexus. Plexus involvement does not causes quadriparesis. It usually present like a monoparesis like presentation. After plexus, there is a nerves. Yes, nerves involvement can causes the quadriparesis, which is usually onset from the distal, progress to the proximal, like in Guillain-Barré syndrome or diabetic neuropathy, alcoholic neuropathy, vitamin B12 deficiency. So, or either congenital neuropathies. So, neuropathy can causes element type of quadriparesis. Then neuromuscular junction. In neuromuscular junction, yes, myasthenia gravis. Myasthenia gravis, which is a neuromuscular junction disorder, can causes quadriparesis, in which there is a fatigability and other symptoms of the weakness. Then muscle disease. Yes, muscle disease can causes the quadriparesis, which is usually proximal type of weakness, or in some cases of muscular dystrophy, there may be selective type of involvement is there. So for quadriparesis point of view, if there is a UMN type or spastic type of quadriparesis, lesion usually in the spinal cord and sometimes rarely in the brain stem and very rarely in the brain. For element type of quadriparesis, lesion may be in the anterior horn cell, maybe at the level of root if involvement of nerves is there with root, polyradicular neuropathy. In plexus does not causes quadriparesis. Nerves involvement, yes, definitely causes the quadriparesis. Distal predominant involvement, neuromuscular junction, myasthenia gravis may present like a quadriparesis in generalized myasthenia, and muscle disorders may present like a quadriparesis. Next, what is difference between the spastic and the flaccid quadriparesis? As we also discussed in the paraparesis, for spastic quadriparesis, so spastic and the flaccid quadriparesis. So for spastic quadriparesis, सबसे पहले बात करते हैं मोटर सिस्टम की. सो न्यूट्रिशन इन स्पास्टिक क्वाड्रिपैरेसिस, नो मसल वेस्टिंग. इन फ्लैसिड टाइप ऑफ पैरापैरेसिस अर्ली वेस्टिंग, अर्ली मसल एट्रोफी, tone increase in spastic type of quadriparesis and tone decrease or flaccidity seen in the element type of quadriparesis. Flaccid type of quadriparesis exception is the cervical myelitis. Power decrease in both but less weakness as compared to element type of weakness. Predominant weakness. Reflexes exaggerated, brisk reflexes seen in the spastic quadriparesis. Reflexes is hyporeflexia or areflexia seen in the element type of quadriparesis. Plantar or extensor. In spastic type of quadriparesis, plantar is flexor or mute. In the flaccid type of quadriparesis, so no muscle wasting in spasticity, increased tone, spasticity, no muscle wasting, less weakness as compared to element type of weakness. Reflexes is brisk, plantar is extension, and clonus may be present. Clonus may be present. In this, clonus is absent. Fasciculation is seen in the flaccid type, may be seen in the flaccid type of quadriparesis. So these are the difference between the spastic and the flaccid type of quadriparesis. For spasticity, we have example of the cervical cord involvement. In this, we have multiple neuropathy, myopathy, neuromuscular junction disorder, and anterior involvement. So this is the difference between the both two. Now comes to the spastic quadriparesis या myopathy. So spastic quadriparesis or myopathy, we see the cord. This is the central canal. So basically there are three main tracks in the spinal cord. First is the pyramidal tract, which is the motor tract or corticospinal tract. If involvement of the pyramidal tract, there is a weakness of the limbs, motor weakness of the limbs. Second is the spinothalamic tract, lateral spinothalamic tract. Third is the posterior column. Fourth is the bladder bowel area. So in spinal cord mainly four areas which is usually important for the quadriparesis point of view: pyramidal tract or corticospinal tract, lateral spinothalamic tract, posterior column and the bladder bowel area. So this area is the posterior column, which is the present in the posterior part of the spinal cord. This area is for the bladder bowel control. This area of the anterior horn cell, from the anterior root is arise. This is the pyramidal tract, and this area is for lateral spinothalamic tract. So basically for myelopathy, there is involvement of pyramidal tract causes weakness in the limbs. Involvement of the lateral spinothalamic tract causes loss of pain and temperature in the limbs, which may causes the burning, unnoticed cut or injury may present. Posterior column involvement usually causes loss of vibration sense, loss of pressure sense, loss of joint position sense. So maybe there is an imbalance in the walking, especially in the when the eye closed, sensory ataxia we call it. So involvement of posterior column causes the sensory ataxia, imbalance on the walking, difficulty in walking. Wash patient ataxia we also say to that. Involvement of the bladder bowel area causes the involvement of the bladder and the bowel. So these are the mainly tract which is useful in the case of the quadriparesis. So this is the posterior column, pyramidal tract or corticospinal tract, lateral spinothalamic tract, bladder areas. Usually if there is a lesion in the intramedullary region, it causes early bladder bowel involvement, anterior horn cell area. So this is the diagram as I discussed. This is the lateral corticospinal tract, pyramidal tract. This is the lateral spinothalamic tract. This is the posterior column. Here are the usually bladder area. This is the anterior horn cell area. Anterior root arises from the anterior horn cell region. So in spinal cord, usually involvement either in the posterior column, lateral spinothalamic, lateral corticospinal tract or lateral spinothalamic, depend on the location of the lesion or type of lesion. So now we discuss about the myelopathy. First we discuss about the compressive myelopathy. So myelopathy is of two types: compressive myelopathy or non-compressive myelopathy. For compressive myelopathy, as I already discussed in the paraparesis lesion, this is the spinal cord substance, this is the white gray matter, outside is the white matter. Usually our tract present in the gray matter. सॉरी व्हाइट मैटर में हमारे जो ट्रैक्स होते हैं कॉर्टिकोस्पाइनल ट्रैक्ट लेटर, ये हमारे यूजुअली जो होते हैं ये हमारे व्हाइट मैटर में होते हैं, अंदर ग्रे मैटर होता है. सो बेसिकली देयर इज अ दिस इज द ड्यूरा. So any lesion outside the dura, it is called as the extradural extramedullary lesion. So like this is the outside the dura, this is the extramedullary extradural. So this is a compressive, this is a lesion compressing the spinal cord. Any lesion which is inside the dura, this lesion is the inside the dura. So this is the intradural extramedullary. Outside the dura, extradural extramedullary. Inside the dura, intradural but extramedullary and outside the spinal cord. Or this lesion is the intramedullary lesion, is present in the parenchyma of the spinal cord. As we already discussed, कि various lesion of compressive myelopathy की lesion is extramedullary, extradural causes different type of presentation, extramedullary, intradural causes different type of presentation, and intramedullary causes different type of presentation because they compresses the structure differently. Like if there is a lesion in the extramedullary, extradural, this is the near the root, so this lesion causes root pain, radicular pain. In this case, there is a spinal tenderness, spinal deformity, to girdle-like sensation. These seen in the extramedullary, extradural lesion. Intramedullary, intradural lesion usually causes weakness of the U-shaped type of classically weakness there. Intramedullary lesion causes early involvement of the bladder wobble. Pain usually funicular diffuse type, is a pain radicular acute pain होगा. So now we discuss the difference between the compressive and the non-compressive myelopathy first. Then we come to the compressive. So in compressive there is a root pain, bony deformity, bony tenderness, girdle-like sensation are the features of the compressive myelopathy. Upper level of sensory loss seen in the compressive myelopathy. Onset usually gradual in the compressive myelopathy. So basically in compressive myelopathy there is a lesion compressing from outside of the spinal cord, and due to the involvement of the root that is arises from the spinal cord laterally may causes root pain, bony deformity and bony tenderness seen in the compressive type of myelopathy. Girdle-like sensation or upper level of sensation are usually feature of compressive myelopathy. Root pain does not present in the non-compressive myelopathy. No bony deformity, no bony tenderness, no girdle-like sensation except in the girdle-like sensation seen in the myelitis. Transverse myelitis or acute myelitis may they be seen. Upper level of sensory loss may be seen in the myelitis but not a feature of non-compressive myelopathy. Onset is usually gradual in the compressive myelopathy and acute onset usually in the non-compressive myelopathy. Symmetricity, compressive myelopathy usually present with the asymmetrical onset and non-compressive myelopathy usually have the symmetric onset. Bladder wobble involvement early in the compressive and usually late in the non-compressive except in the myelitis. So this is we already discussed in the paraparesis case. Now we comes to the different comparison between the spinal cord syndrome like extramedullary, extradural, extramedullary, intradural and intramedullary. So this is the extramedullary, extradural outside the medulla, yani spinal cord or outside the dura. It usually onset usually rapid. Spinal tenderness, I discussed the involvement of the spinal vertebrae, so may cause the spinal tenderness. Root pain is common, but in intradural, extramedullary onset usually slow, no spinal tenderness here rare, no root pain. In intramedullary lesion there is a very slow onset, spinal tenderness is absent, no root pain. Position sense usually involvement of the posterior column usually seen in the extramedullary, extradural region. Early loss this is spared. Pain and temperature involvement loss in all three. Sacral loss, this is very important. Sacral sparing seen in the intramedullary lesion because sacral fiber most outside in the spinal cord. So sacral fiber more outside the spinal cord. So any lesion that is arise from the substance of the spinal cord or inside the medulla, intramedullary causes their involvement of the sacral fiber. So sacral sparing is a features of intramedullary lesion. Early bladder, as I say, bladder fiber is near this area. So early involvement of the bladder wobble and sacral sparing are the classical features of the intramedullary type of lesion. So this is the difference between the compressive myelopathy. There are three type of presentation: extradural, extramedullary, intradural and intramedullary. Three types of there. So now comes on the spinal cord syndrome. So अभी तक हमने डिस्कस किया कि स्पाइनल कॉर्ड में ब्रेन से लेके स्पाइनल कॉर्ड तक कहाँ लीजन हो सकते हैं, एलिमेंट टाइप ऑफ रीजन, यूएमएन टाइप ऑफ रीजन, कैसे कैसे वैरायटी ऑफ प्रेजेंटेशंस हो सकते हैं. नाउ वी डिस्कस द स्पाइनल कॉर्ड सिंड्रोम. We already discussed these in the approach to the paraparesis, but we again discuss. So this is the spinal cord, this is the central canal. So this is the corticospinal tract या pyramidal tract. This is the lateral spinothalamic tract. This is the usually bladder fiber, and this is the posterior. As we discussed, pyramidal tract arises from the cortex, goes down and crosses at the level of medulla to the opposite side, and in spinal cord this present on the same side where the lesion occur. If right side of the body controlled by the left side of the pyramidal tract, it crosses at the medulla, and in spinal cord they control the same side of the motor function. For lateral spinothalamic tract, they crosses the midline at the level of the spinal cord. So any lesion in the spinal cord causes involvement of the pain and temperature on the opposite side of the body, but weakness and the joint position sense or vibration sense on the same side of the body. So there are many types of syndrome like anterior cord syndrome, anterior cord syndrome usually seen in the involvement of the anterior spinal artery thrombosis. So in anterior cord syndrome there is an involvement of the pyramidal tract and involvement of the lateral spinothalamic tract only, and sparing of the posterior column. So in anterior cord syndrome there is a weakness of the limbs, if quadriparesis, weakness of the all four limbs, and loss of pain and the temperature sensation, but preservation of the posterior column sensation like joint position, vibration and the pressure. So in anterior cord lesion there is a weakness of the limbs, motor weakness plus involved the spinothalamic tract, and there is a loss of pain and temperature but sparing of the posterior column. In posterior cord syndrome there is an involvement of the posterior column mainly and sparing of the motor areas, motor tract and the lateral spinothalamic tract. So in posterior cord syndrome, like in posterior spinal artery thrombosis or in subacute combined degeneration due to B12 deficiency, may causes only involvement of the posterior tract, which causes loss of the joint position sense, vibration sense and the pressure sense, in which there is a sensory type of ataxia is there. One syndrome is there, the hemicord syndrome. In hemicord syndrome, there is an involvement of the posterior column, corticospinal tract and spinothalamic tract. So in hemicord syndrome, there is an involvement of posterior column same side, corticospinal tract and lateral spinothalamic tract. So in hemicord syndrome, because as I say ki spinothalamic tract, if this is the brain, this is the cord, in spinal cord, fiber from the lateral spinothalamic tract crosses the midline and goes opposite side to the thalamus and to the cortex. Pyramidal tract crosses at the level of medulla and goes down and supplies to the same side. So in hemicord lesion, if there is a lesion on the left side of the cord, it causes weakness and posterior column involvement on the same side and pain and temperature loss on the opposite side of the body. So in hemicord syndrome, if there is a lesion in the left side, it causes weakness of left side of body, loss of posterior column on left side and involvement of loss of pain and temperature on the right side. So राइट साइड में पेन एंड टेम्परेचर लॉस होगा इन ब्राउन स्क्वाड सिंड्रोम या हेमिकॉर्ड सिंड्रोम में, और सेम साइड में पोस्टीरियर कॉलम एंड द मोटर इन्वॉल्वमेंट प्राइमरी ट्रैक्ट का इन्वॉल्वमेंट वीकनेस है. दिस इज द स्पाइनल कॉर्ड सिंड्रोम. सेंट्रल कॉर्ड सिंड्रोम यूजुअली कॉजेस अर्ली इन्वॉल्वमेंट ऑफ द ब्लैडर एंड द बॉवल एरियाज. So now for compressive myelopathy we discuss the various presentation of compressive myelopathy. So in compressive myelopathy classically in exam you may get case of cervical myelopathy. So in cervical myelopathy usually there is a compression in the cervical cord which causes involvement of the both side of the upper limb, both lower limb. Usually follow sometimes U-shaped pattern. That there is a weakness of one side of the body first, upper limb, then lower limb, then opposite lower limb, then the opposite upper limb. So gradual presentation होता है, gradually progressive होगा, पेन होगा, सर्वाइकल पेन होगा, रेडिकुलर पेन होगा, रेडिएट करेगा अपर लिम्ब को. तो इन सर्वाइकल और कंप्रेसिव माइलोपैथी ग्रेजुअली प्रेजेंटेशन होगा, पेन, रेडिकुलर पेन होगा, वीकनेस होगी, सेंसरी इन्वॉल्वमेंट होगा, टिंगलिंग सेंसेशन, पैरास्थेसियाज होगी, वीकनेस होगी, ग्रेजुअली प्रोग्रेसिव वीकनेस होगी. लेट ब्लैडर वॉवल इन्वॉल्वमेंट लेट होता है, बिकॉज जब कंप्रेशन बढ़ेगा इंटरनल जो ब्लैडर वॉल्व है वो लेट इन्वॉल्वमेंट होंगे. आपको यूएमएन टाइप ऑफ क्वाड्रिपैरेसिस मिलेगा, डीटीआर ब्रिस्क होंगे, हाइपररिफ्लेक्सिया मिलेगा, प्लांटर एक्सटेंसर मिलेंगे, टोन बढ़ी हुई मिलेगी, स्पास्टिसिटी मिलेगी. तो स्पास्टिक टाइप ऑफ क्वाड्रिपैरेसिस seen in the compressive type of myelopathy. Gradual onset, pain, cervical pain, radicular pain, weakness, sensory involvement, late bladder wobble involvement, UMN type of presentation. This is seen in the compressive myelopathy. Then the non-compressive myelopathy. Non-compressive myelopathy, we have various causes like myelitis, cervical myelitis, which may be the post-infectious or post-inflammatory. Post-infectious, may be neuromyelitis optica, may be seen in the multiple sclerosis, may be seen in the anti-myelin oligodendrocyte antibodies. Oligodendrocyte antibodies disease. So in myelitis, these for non-compressive myelopathy, for example, this may be the case, or there are other causes like SACD, subacute combined degeneration, infective, sometimes cervical POTS. Cervical POTS usually causes the compressive myelopathy. So for non-compressive myelopathy, main focus is on myelitis. Usually in exam may get the case of the quadriparesis, which may be due to the post-infectious or post-inflammatory myelitis, NMO spectrum disorders, involvement, multiple sclerosis and anti-MOG disease. So for non-compressive myelopathy, these are the common causes. इसके अलावा the SACD subacute combined degeneration may be a case of the non-compressive myelopathy. So now element causes of quadriparesis. So till now we discussed the UMN type of quadriparesis, especially focus on the spinal cord, brainstem rarely causes quadriparesis. Then the non-element causes of the quadriparesis. For element causes, so as already discussed, in element point of view, we have lesion on the anterior horn cell, nerve, as root or plexus usually does not causes the quadriparesis. Muscle and the neuromuscular junction. So we discuss one by one. So for anterior horn cell, there is a involvement of the UMN. Presentation is UMN plus element both. Usually atrophy is there, fasciculation is there, gradual onset, slowly progressive. Classical example are the motor neuron disease. So for anterior horn cell, like motor neuron, UMN plus element both features are there. Atrophy, early atrophy, fasciculation, gradual onset, slowly progressive. बाकी UMN feature like increased tone, hyperreflexia, extensor plantar is extensor, no involvement of sensory, no sensory involvement, and no bladder wobble involvement. So for anterior horn cell lesion, UMN plus element mix, early atrophy, fasciculation, gradual onset, slowly progressive, UMN type of feature, increased tone, hyperreflexia, plantar extensor, no sensory or no bladder wobble involvement. For nerves, there is a distal onset involvement, predominantly distal onset, involvement of the distal areas first, then progress to the proximal. Follow the nerve distribution. Follow nerve distribution. Nerve distribution like involvement of the median, involvement of the ulnar, radial, in lower limb, femoral, peroneal, tibial. So involvement is according to the nerve distribution. Where the nerve goes, involvement according to that. Muscle involvement is according to the nerve distribution. So in neuropathy, nerve involvement element type of quadriparesis, there is a distal onset, progress to the proximal. Pain, nerve pain should be there, like tingling sensation, paresthesias, burning. These sensations are numbness in negative symptoms. So pain, neuropathic pain like tingling sensation, paresthesias, burning, numbness, heat like sensation, electric like sensation. So nerve pain, follow nerve distribution, distal involvement, then proximal involvement. So motor plus sensory involvement. No bladder bowel involvement in usually in the peripheral neuropathy. Yeah, late sometimes, rarely involved like in a GBS or maybe transient involvement. Then element type of pattern. Muscle atrophy may be present if there is a severe neuropathy, DTR, hyporeflexia, plantar mute or flexor, maybe flexor. So element type of quadriparesis with no bladder bowel involvement, motor plus sensory involvement. Pain is mainly distribution along the nerve, distal onset, then reaches to the proximal. In GBS, there is an involvement of the proximal muscles also. Ascending type of quadriparesis, in some cases may involvement of the bulbar areas or involvement of fascia. For muscle, in muscle, there is a depend on the presentation, acute presentation, gradual or episodic. In acute presentation, there is a inflammatory muscle disease. Inflammatory causes may be there, like post-viral myositis, polymyositis, dermatomyositis, and inflammatory myopathy is in group of the acute onset myopathy, muscle disease, inflammatory post-viral myelitis, and polymyositis and the dermatomyositis. So in acute, there is a inflammatory causes of the muscle involvement. In gradual onset, there is a muscular dystrophy. So in inflammatory muscle disease, there is a muscle pain. Muscle pain is basically dull aching pain, cramps like pain, involve the muscle. Diffuse pain does not causes electric like sensation or paresthesias. No sensory loss in the muscle disease, no bladder bowel involvement, no muscle atrophy. Deep tendon reflexes may be preserved, plantaris flexor. So these are the feature of the muscle disease. No atrophy, DTR normal usually. But in muscular dystrophy, which is the gradual onset, slowly progressive gradual onset, depend on the type of muscular dystrophy. There is a various presentation, like selective involvement of the muscle, like in scapulohumeral disease, there is involvement of facial muscle, scapular muscle, humeral muscles. In limb girdle dystrophy, there is a proximal involvement of mainly girdle muscles. So depend on the DMD, there is a mainly involved the lower limb proximal muscles. So basically in muscular dystrophies, there is a gradual involvement, selective involvement of the muscle group. So different type of presentation is there in acute. If there is a episodic type of muscle weakness, which is seen in the hypokalemic periodic paralysis and in thyrotoxicosic periodic paralysis, which causes the episodic type of weakness, which causes weakness improved after the correction of the potassium or correction of the thyrotoxicosis. So this is the muscle disorder. Then the NMJ disorder, neuromuscular junction disorder. So NMJ is specifically like myasthenia gravis, mainly the prototype of the NMJ disorders. Fatigability is the characteristic feature. Like fatigability means when patient awake in the morning, weakness is less. As day passes, weakness increases. So fatigability, like if when he started chewing or talking, initially there is a difficulty less. As he effort is increases, the difficulty in speaking or chewing increases with time. This is the fatigability. Pure motor involvement, no sensory, no bladder bowel involvement. Diurnal variation may be there as fatigability is the main. So diurnal variation is a feature of fatigability. Presence of antibody, which all this is a autoimmune type of disease. So in myasthenia gravis there is a fatigability, pure motor involvement, no pain. Diurnal variation may be involvement of the bulbar or the respiratory features, may be involved the ptosis because it causes involved the ocular also. If generalized myasthenia, it is usually quadriparesis like presentation may be there, fatigability is there. If ocular, there is a ptosis and the diplopia may be there. So diplopia, ptosis, bulbar involvement, respiratory involvement in late stage, fatigability, pure motor, diurnal variation are the feature of the myasthenia gravis. So this is all about element type of quadriparesis. Quick in revision. Lower motor neuron paralysis or flaccid quadriparesis, anterior horn cell motor neuron disease, LM and UM दोनों features, atrophy, no bladder bubble, no sensory, fasciculation, gradual onset, UMN feature, tone increase, hyperreflexia, plantar extensor, nerve involvement, mainly distal, then proximal, follow nerve distribution like ulnar, median, radial, which nerve is involved, distribution is that, pain, nerve pain, electric light sensation, paresthesia, tingling, then no bladder bubble involved, motor plus sensory involved, element type of feature is there. For muscle disease, acute, gradual, episodic, inacute inflammatory myopathies. For gradual muscular dystrophies, selective involvement of the muscle group. For neuromuscular dysfunction, myasthenia gravis, fatigability, pure motor, diurnal variation, and other features should be there. Now, as we discussed, anterior horn cell, upper motor neuron, lower motor neuron, atrophy of the muscles, fasciculation, no sensory involvement, no bladder, and asymmetric onset. For neuropathy like vitamin B12 deficiency, diabetes, alcoholic, GBS, distal onset, proximal in GBS, gradual, acute, sensory symptoms, ascending type, LMS sign, and the sparing of the bladder bubble. Then this is the GBS. GBS may be seen in the exam case. So preceding infection history like Campylobacter jejuni. So history of diarrhea is important in case of GBS. Vaccination history, onset is acute, ascending type of paralysis. Progress to upper limb, bilateral facial involvement may be there, and bulbar and the respiratory involvement in the severe cases. Bladder involvement is rare in the GBS. So this is also we discussed like NMJ, we discussed the fatigability, diurnal variation, ptosis of the diplopia, pure motor weakness, sensory and bladder bubble sparing, bulbar and the respiratory involvement in the severe cases. So this is all we discussed. In myopathy, so the acute onset, gradual onset, episodic, we all discussed this also. Now comes to the history taking. So till now we discuss about the how we approach a quadriparesis, UMN type, element type. Element type we discuss the various presentation. Element type we also discuss the various type of presentation. Now history taking. History taking is similar to the history of the paraparesis, like duration of the symptoms, like motor weakness, sensory weakness of bladder bubble. How many days involvement is there? Onset is acute. Gradual onset, acute onset in the myelitis, gradual onset in the compressive myelopathy, progression, slowly progressive in the compressive myelopathy, slowly progressive in the muscular dystrophy, slowly progressive in the compressive myelopathy, slowly progressive in the acute onset or acute progression seen in the Guillain-Barré syndrome. Limit progression is a associated symptoms like any history of fever for the infection, any cervical pain, the compressive myelopathy, any radicular pain for the compressive myelopathy, any pattern of the sensory loss, how is there, history of vaccination of preceding infection of diarrhea for the GBS, history of headache, seizure for the cerebral causes, history of trauma for the cervical trauma may causes the compressive myelopathy like presentation, alcohol intake for the neuropathy, vegetarian diet for the vitamin B12 deficiency, fasciculation for the anterior horn cell disease or the motor neuron. History of pulmonary TB or the diabetes for the comorbidities or may causes the. Then in examination point of views, motor system examination, like we can see the wasting for the element type, weakness, proximal involvement or the distal involvement, proximal involvement seen in the muscle disease, distal involvement usually seen in the neuropathies. Tone for the difference between the UMN and the LMN. If tone is increased, the chances of the cervical cord lesion is there. If tone is decreased, sometimes in cases of myelitis, tone may be decreased due to the spinal soft stitches. DTR, superficial infection like plantar extensions in the UMN type of lesion. Sensory examination, cerebellar for the multiple sclerosis, examination of the spine for the deformity and the tenderness for the compressive myelopathy. So this is the various examination. We discussed this in detail in the examination. Now for the investigation, MRI spine and the MRI brain. MRI cervical spine to look for the compressive myelopathy. If there is a compressive myelopathy or a non-compressive myelopathy. For non-compressive, the main cause is the myelitis. So we look for the MRI brain. If we are suspecting the lesion in the brain, we go for the MRI. Nerve conduction studies and the EMG nerve conduction for the like GBS, CIDP, chronic inflammatory dermatitis, with usually the common presentation of the quadriparesis in exam. EMG for the muscle disease or for the motor neuron disease, we go for the EMG. CSF examination for GBS, like in GBS we see the GBS and the CIDP, we may see the albuminocytological dysfunction. Protein is increased, sugar is normal and cells is normal. So albuminocytological is a feature of GBS and the CIDP. So this is the features of CBA. Vitamin B12 usually we see for the subacute combined degeneration if we are suspecting, and blood sugar for the diabetes. CPK level is seen in the myopathy के लिए. Very high CPK level seen in the inflammatory myopathy and sometimes in the muscular dystrophy like DMD and the BMD. So for muscle disease or myopathy, we go for the CPK level, we go for the EMG. RNST repeated nerve stimulation test for the myasthenia gravis. If we are suspecting myasthenia gravis, we go for the repetitive nerve stimulation test in the nerve conduction studies. Then various antibodies testing, like for multiple sclerosis, we go for the oligoclonal band in CSF or serum. For NMO, neuromyelitis optica spectrum disease, we go for the aquaporin 4 antibodies, or we may go for the anti-MOG antibodies for the, or myasthenia gravis, we may go for the anti-acetylcholinesterase antibodies. So this is the investigation for the quadriparesis. Main investigation is the MRI brain and NCDs, EMG. These are the main investigations. Other than CPK level, vitamin B12, any routine profile, RNST, antibodies, depend on the what we are suspecting as a cause. So for diagnosis, anatomical diagnosis is quadriparesis, like patient present with the weakness of the all four limbs. Various presentation as I discussed, distal weakness predominantly, proximal weakness predominantly, involvement of the one side of upper limb, then lower limb, then opposite side progresses, asymmetric type of involvement, symmetric type of involvement in all limbs, or involvement same time like in myelitis. Localization in the brain usually does not cause classical quadriparesis. Spinal cord is the main site, and nerve, muscle, anterior horn cell, NMJ. These are the classical presentation as a quadriparesis. So for quadriparesis point of view, main localization for UMN is the spinal cord. For element type of region, nerve, muscle, anterior horn cell, and the NMJ. What is the pathological diagnosis? Spastic, flaccid, compressive, non-compressive. Etiological diagnosis as I discussed, the vitamins. V for the vascular. In vascular, we have the anterior spinal artery thrombosis or posterior spinal artery thrombosis. In infection, we have the may have the Pott's spine. For trauma, T for trauma, traumatic may causes. Toxin like letharism may causes quadriparesis, usually present with paraparesis. Autoimmune, in autoimmune we have important causes like multiple sclerosis, myelitis, post-infectious myelitis, NMO spectrum disorder, and the anti-MOG spectrum disorders. For metabolic we have the hyperthyrotoxicosis induced quadriparesis, episodic quadriparesis. For iatrogenic or idiopathic, sometimes there is a maybe we do not find the cause. For nutritional, we have the vitamin B12 deficiency. For syndromic, and in syndromic we have the muscular dystrophy. In degenerative, we have the anterior horn cell disease like motor neuron disease. So in metabolic the diabetes is also there. So these are the causes of the myelopathy and how we approach a case of quadriparesis. For management depend on the cause, maybe conservative management, maybe surgical if there is a compressive myelopathy. For compressive myelopathy, a cervical compression, surgery is the best option. If there is a compression is severe, which causes the quadriparesis. For non-compressive myelopathy, usually conservative treatment is there. If there is a inflammatory or inflammatory cause like myelitis, steroid is the option. Methylprednisolone pulse therapy for the 5 days. If there is a Guillain-Barré syndrome, then the IVIG therapy. If there is a neuropathy, depend on the cause, we treat that cause. For motor neurology, there is no definitive treatment is available. Physiotherapy and rehab in the all cases of the quadriparesis. So today with this we approach as a case of quadriparesis. We discuss where is the lesion, what may be the lesion, or why this lesion occur. For where we discuss the brain stem, which really causes quadriparesis. Spinal cord, cervical spinal cord is the main area where the UMN type of quadriparesis may occur. In element type of quadriparesis, anterior disease, anterior involvement, nerve involvement, muscle involvement and neuromuscular junction involvement may causes quadriparesis. So this is all about the how to approach a case of quadriparesis. So thank you again. So अगर आपका कोई भी doubt है, if you have any question, any doubt, you can comment us. We definitely give answer for any query, any further if you want any case about the approach. So you may talk with us, you may comment us. हमारे चैनल को लाइक करिए, वीडियो को शेयर करिए और हमारे चैनल को सब्सक्राइब करिए. थैंक यू.